Hello and welcome once again, my friends. My name is Dr. Saeed Kazmi, you watching my YouTube channel. And today we will be talking about Haemolytic Uremic Syndrome, which is also known as HUS in abbreviation. Now, Haemolytic Uremic Syndrome is a rare condition, but it's basically a clinical syndrome which is characterized by acute kidney injury, which is associated with microangiopathic hemolytic anemia and thrombocytopenia. So, it's kidney injury plus microangiopathic hemolytic anemia plus thrombocytopenia. Now, why it occurs? Number one, infection with Shiga toxin producing E. coli, and I would call them as Aztec E. coli. So Aztec standing for Shigella toxin producing E. coli. Now, this is one of the most common causes of hemolytic uremic syndrome in the pediatric population, accounting for up to 90% of all cases under the age of 5 years. Now, the most common strain of Aztec HUS is E. coli 0157H7. But recently another strain, which is the E. coli 104H4 or 104H4, that has also been discovered in Western Europe. Now, this has got a primary means of transmission through undercooked food, which in most of the cases is beef, and some less common sources, including person to person or direct animal contact. Now, children are more affected than adults, and the causes, diagnosis, and management are essentially the same for adults as well as children. But essentially, we would be talking regarding the care of children in this particular lecture. Now, to start with, hemolytic uremic syndrome can be basically classified into acquired and hereditary causes. This is an old classification, or you can simply say primary and secondary. Now, the Aztec associated hemolytic uremic syndrome is basically a typical secondary cause of hemolytic uremic syndrome. So basically the common one, which is the Aztec HUS, this comes under the umbrella of the secondary cause of hemolytic uremic syndrome. Now, other culprits in this category of secondary hemolytic uremic syndrome include infections with Streptococcus pneumoniae, HIV, some of the drug toxicity. Sometimes pregnancy even can precipitate hemolytic uremic syndrome, and some of the autoimmune disorders including SLE. Now, primary category, the primary hemolytic uremic syndrome, it is also known as atypical HUS, atypical hemolytic uremic syndrome. Now, this is basically sort of a hereditary syndrome, and it is often due to complement gene mutations. Sometimes it can be because of antibodies to complement factor 8, or some of the gene mutations in the gene which is responsible for diacylglycerol kinase epsilon, and some inborn errors of metabolism, especially the inborn errors of cobalamin C. So I mean these are what we call as primary or atypical hemolytic uremic syndrome, but by and large, again, most of them, they occur because of problems or gene mutations in the complement activation cascade. So keep this thing in your mind. Now, coming back to the pediatric hemolytic uremic syndrome, and I told you most of the causes are because of Aztec, that is the Shigella toxin producing E. coli. So basically, the virulence of this the Shiga toxin producing strains of E. coli comes from the production of this toxin, Shiga toxin. Now, by and large, this is produced by E. coli, but sometimes it can also be produced by certain species of Shigella dysentery. So again, I told you these two bacterial infections of the GIT are usually caused by consuming raw food, mostly undercooked or uncooked beef. Now, when a person or a child is infected with these Shigella toxin producing E. coli or Shigella dysentery, the release of the Shiga toxin causes what? Widespread microangiopathic injury. So basically, these are small blood vessels where there is angiopathic injury. So there is a damage to the endothelial because of damage to the inner linings of the blood vessel, and that leads to a reactive prothrombotic state. Now, this prothrombotic state, and what happens, prothrombotic state causes thrombi, and these thrombi, they consume platelets. So a large number of platelets are consumed. So this prothrombotic state combined with this high platelet consumption leads to formation of intravascular microthrombi. And these intravascular microthrombi, they clog the afferent vessels of the kidneys, and that causes acute kidney injury. The microangiopathic hemolytic anemia basically results from the shearing forces or the shearing of the RBCs. So these RBCs, as they pass through these small tiny micro thrombi, what happens? They are sliced, and that leads to damaged RBCs, and these sliced RBCs have got a characteristic look under the microscope when the hematologist examines them on a blood smear, and they are known as schistocytes. So schistocytes are nothing but what? Damaged RBCs, which you see in the blood smear. Now coming down to the clinical presentation, I mean, you can see the chart behind me. So the classical prodrome illness of children with ASTAC hemolytic uremic syndrome is basically abdominal pain, nausea, vomiting, diarrhea, which can sometimes be accompanied with a fever as well. The diarrhea is usually non-bloody to begin with, but turns bloody within 1 to 3 days. Now, the initial illness typically resolves within a week. So a child has got gastroenteritis symptoms, which usually resolve within 6 to 7 days. But usually the complication of hemolytic uremic syndrome, if they are occurring, that usually arises between 5 to 2 weeks after the initial onset of symptoms. So once the symptoms start, it occurs somewhere within a week to 2 weeks time. Now what happens when these children, they develop HUS? So they present with pallor, because RBCs are being destroyed, hemoglobin is low, so they present with pallor. They have got decreased energy, so they feel very weak. They might have oliguria, that they are passing less urine. So if the baby is still in diapers, mom would say that he's less sweating of his diapers. Or sometimes they may develop edema of the peripheral. I mean, and that happens in a setting of a recent GI infection. So if somebody has got decreased energy, they've got pallor, they are not producing urine, or they've got edema and they had gastroenteritis in the recent past, that should be very, very highly suspicious for hemolytic uremic syndrome. Now, despite that they have got thrombocytopenia on their blood smear, there is rarely evidence of purpura or active bleeding. So they would not present with purpura or purpuric spots or active bleeding. Additionally, they say up to 1/3 of these patients with HUS may have CNL's involvement. So it's rare, but they can have an altered mental status like drowsiness. They might have seizures, maybe develop, they go into coma, or sometimes have stroke, like resulting in hemiparesis. Now, it's also important to differential diagnose hemolytic uremic syndrome with some of the other common pathologies which can present with similar symptomatology. So some of the pathologies are often mistaken for hemolytic uremic syndrome. So remember, it's not that much common in life, but still you should be able to differentiate it from some conditions. So if you look at this chart, you should be able to differentiate it from other invasive gastrointestinal infections, especially caused by Salmonella, Campylobacter, Yersinia, or invasive amoebiasis. So they also have got abdominal pain, they've got bloody diarrhea, they've got high fever to begin with. They might even have high blood urea nitrogen or high urea because of volume depletion, because they've been vomiting and they've been having diarrhea. But remember, how do you differentially diagnose it from hemolytic uremic syndrome? That if you do blood, there will be no thrombocytopenia and there will be no hemolysis. There will be no hemolytic anemia, there will be no thrombocytopenia in these particular cases, though they do present with like GI symptomatology. The other important thing that you have to differentiate it from is disseminated intravascular coagulation. So disseminated intravascular coagulation can also present with hemolytic anemia. They can also present with thrombocytopenia. They also can have acute kidney injury. So very much similar to hemolytic uremic syndrome. But what is special characteristic of DIC, which you do not find in hemolytic uremic syndrome, is D dimer. So elevated D dimers you will find in DIC, but not in hemolytic uremic syndrome. So with D dimers, you know, so if D dimers is raised, you have got problem with your coagulation cascade, and that DIC. With elevated D dimer, they would be having low fibrinogen and they would be having prolonged PT or APTT. So that's how you differentiate hemolytic uremic syndrome from disseminated intravascular coagulation. The third thing is what we call the elder sibling of hemolytic uremic syndrome, that is the thrombotic thrombocytopenia purpura. So thrombotic thrombocytopenia purpura is basically HUS, but it has got a lot of CNS involvements. So they more present with almost like the similar symptomatology. But remember, the one important point that differentiate hemolytic uremic syndrome from uh, thrombotic thrombocytopenia purpura is number one, very high frequency of CNS involvement, but on lab findings you will find that they have got low Adams ST13. So that is basically a protein associated with von Willebrand. So that would be low in case of thrombotic thrombocytopenia purpura, but normal in case of hemolytic uremic syndrome. And last but not the least, systemic vasculitis. Systemic vasculitis can affect any organ. They can also result in acute kidney injury, and they can lead to anemia as well, because obviously there's inflammation of blood vessels, and that would lead to thrombi, and those thrombi can damage our RBCs, and that would lead to anemia. But remember, in that particular cases, they do not have like sort of a history of preceding diarrheal illness. Plus, they have got more involvement of systemic symptomatology. So they would be having a palpable rash. They might have arthralgia, joint pains, and the thing is that there is more involvement of the peripheral nervous system as compared to the central nervous system. So that's like, they can have like mononeuritis mostly in systemic vasculitis rather than, central nervous system involved, which again by and large is quite rare in hemolytic uremic syndrome. So remember, these are some of the clinical as well as the lab features with the help of which you should be able to differentiate it from some other similar conditions. So remember, these are other bacterial invasive infections. Remember, in that case, you won't find thrombocytopenia, you won't find hemolytic anemia. DIC, always elevated D dimer. Thrombotic thrombocytopenia purpura, remember, low Adams ST13. And with systemic vasculitis, you will be having rash, you will be having arthralgia, and there will be mostly, like if there is any CNS involvement, that will be peripheral, okay, rather than the central one. So that's how you differentiate it from some of the other similarly presenting conditions. Hope you have understood that. Now, moving further, how do we diagnose it? Now, the first step is a good history. Now, remember, it usually starts with acute onset of bloody diarrhea and abdominal pain, or there are patients who are basically got a history of being exposed to those patients who have got STAC, usually, or there's a common what we call as a point source outbreak. So some of the initial lab tests that you need to do is full blood count, your UNEs, including creatinine, urine analysis to see if there is any proteinuria, hematuria, stool specimen for culture. So see, you have to culture E. coli or Shigella dysentery, and you can do the stool test for Shiga toxin as well. So these are some of the initial tests that you would do. The full blood count would show you microangiopathic hemolytic anemia, so the hemoglobin would be low. And remember, if you do Coombs test, which we normally don't do in the pediatric emergency department, but if somebody does a Coombs test, that Coombs test would be negative. So you've got a hemolytic anemia, low hemoglobin, negative Coombs test, and the smear would show you schistocytes. So schistocyte and helmet cells are characteristic hematological findings of hemolytic uremic syndrome. Thrombocytopenia would be present. That's usually a platelet count below 140 or 150 thousand per cubic millimeter. You would see that there is an evidence of AKI in the form of elevated creatinine, and you might have hematuria on urinalysis as well. You have to do coagulation studies because it's very important. That would differentially diagnose it from DIC. There are some of the other tests which can be done for the primary hemolytic uremic syndrome, like complement studies. Low complement C3 levels are common, and if the complement cascade pathway problems are present. But anyhow, because they are rare, I will not go into the details of that. Nelson has got a table in which all those special type of tests are given, which can be done if somebody suspecting atypical HUS. Now, as far as treatment is concerned, as far as the hemolytic uremic syndrome caused by STAC is concerned, remember, there is a positive association between volume depletion and adverse outcomes. So remember, if the patient can tolerate it, the treatment is giving them fluids, either oral fluids or IV fluids, and you have to monitor electrolytes very closely because there can be likely change to pH and fluid shift from the profound diarrhea. Now, anemia is common complication due to hemolytic anemia. So one has to stay on top of this, and if needed, a packed red blood cell transfusion whenever the hemoglobin is below 6 or 7, depending on different books or different trusts have got different guidelines, or the hematocrit is less than 18%. Again, follow whatever your own guidelines are say. And sometimes emergent dialysis might be needed, peritoneal or hemodialysis might be needed in critically ill patient. Now remember, some people think antibiotics because this is a bacterial infection. No, there is no role for antibiotics. Rather, antibiotics would worsen that, because antibiotics would, when they kill these bacteria, more Shiga toxin is released, and that is just going to create havoc with the um, with the clinical syndrome. Now, studies have shown an increased incidence of hemolytic uremic syndrome in children when they were treated with antibiotics. So they say that sort of in observation studies, there has been a risk of 2.24% between antibiotic use and hemolytic uremic syndrome. Uh, as far as the atypical hemolytic uremic syndrome is concerned, again, usually it is treated with plasmapheresis to begin with. In the first few days, they do plasmapheresis. If that is successful, well and good. If the plasmapheresis doesn't work, then there is a monoclonal antibody which is known as eculizumab. So eculizumab is used only for atypical hemolytic uremic syndrome. It's a very expensive drug, so it's usually given under the care of a pediatric nephrologist. But to begin with, it always starts with plasmapheresis, and if it doesn't work, then eculizumab. Most of these patients have got a good prognosis. Usually the renal function, if it is like T-range, usually comes back to normal within 1 to 2 weeks. Well, if there is CNS involvement, the mortality is a bit high. It can go up to 4% in certain cases. But remember, if there are other like sort of ongoing morbidities, comorbidities, then the mortality rate is a bit high. But as I told you, in case of Aztec HUS, usually there's good recovery within 1 to 2 weeks, while in case of atypical hemolytic uremic syndrome, some of them, they usually 50 to 60%, they usually recover within 4 to 6 weeks. But remember, for those patients who have got low grade symptomatology or they do not fully recover, that's very important that they have got ongoing monitoring of their renal functions and other things from time to time to see that there is not much damage going on. And obviously, if there is damage, then it has to be managed accordingly. Sometimes nothing works, they eventually go into frank renal failure, where the only hope is kidney transplantation, but again, that's quite rare. So this was all about hemolytic uremic syndrome in pediatric population. Remember, in pediatrics, it's mostly the secondary hemolytic uremic syndrome caused by Shiga producing E. coli or Shigella dysentery. And but remember, there can be a primary hemolytic uremic syndrome as well, caused by mostly complement defects. So I hope you have liked this lecture. If you still haven't understood anything, please do ask me. And if you've liked the video, please give me a thumbs up, share it with your friends. And if you haven't subscribed to my channel, please do subscribe. Have a very good day. Take care and bye-bye.